A very good morning to all of you. So here we are all together with unity for the second continuous day of the 7th International Conference on Multidisciplinary Approaches, iCMA 2020, to exchange our knowledge and experience for a better future. Now it's time for the day 2 theme talk of this conference. Today, we are honored with the presence of a leading scientist in Sri Lanka, who is a phenomenal character in Sri Lanka's battle against COVID-19, Professor Neelika Malavige. Professor Malavige is a head of the Department of Immunology and Molecular Medicine and also the director of the Center for Dengue Research, University of Sri Jayewardenepura. She is an Associate Fellow of the Higher Education Academy UK, member of European Academy of Allergology and Clinical Immunology, member of the British Society of Immunology, and a member of the American Society of Tropical Medicine and Hygiene. She also is an academic visitor at MRC Human Immunology Unit, University of Oxford, and a member of the Executive Committee of the International Society of Infectious Diseases. Professor Malavige has been working on immunopathology and correlates of protection on dengue and now also works on immune response to SARS-CoV-2. These days, she and her team are working around the clock assisting health authorities amidst the pandemic. Today, Professor Neelika Malavige will enlighten us on the topic of fight against COVID-19 and can we succeed? A very timely topic. Ladies and gentlemen, please welcome Professor Neelika Malavige to deliver the theme talk. I would like to call upon Senior Professor Patmalal Manage, Senior Professor Kamani Vanivasuriya, Senior Professor Sadun Senarat, and Professor W. Dhanapala as the panelists of the present session. There's a very reputed audience of distinguished academia today to listen to this theme talk, both on site and online. So let's mark the commemoration of the theme talk. Thank you.
Okay, thank you for giving me this opportunity to talk about a very timely topic, which is COVID. Everybody is interested in it, and because everybody is affected by the current COVID situation. So all of this started, or we got to know about it only last December, when we heard about this mysterious pneumonia-like illness occurring in China. And of course, the first patient died in the first week of January. And then only the Chinese government accepted that this mysterious pneumonia-like illness does spread among humans. And after that, the rest is history. We know that as of today, 68 million individuals have been infected with the virus. That is 68 million reported cases. But we know that the WHO estimates that 10% of the world population have been infected. That is 700 million people have been infected by COVID up to now. And the deaths are more than 1.5 million. Now, Sri Lanka had a good time. I know we started off with identifying the first patient in March 10th this year, but March 10th this year, and we went for a very early lockdown on the 20th of March when we just had identified 66 patients. And because of that, we were able to contain the epidemic, and we went on for a very prolonged lockdown of 8 weeks and limited lockdown for another 2 weeks. So during this period, we had small clusters like the CMC cluster, which we saw in April, then the Navy cluster. I can get my power pointer.
Make 1 minute.
Yes, so, and my point option is out. and patients from Middle East returnees. And then we had the famous Kandahar outbreak from the Drug Rehabilitation Center, and we did see the outbreak spreading to the rest of Sri Lanka, but it was contained. Then we had a disease-free period, or no locally infected patients were identified from August and September. So that was our honeymoon period. Everybody was happy. Nobody wore masks. Everybody was not following the new normal, but the usual they were used to. But all of a sudden, in early October, all of us were in for a surprise with the identification of this outbreak in a clothing factory in Sri Lanka. And since that, of course, we know that every day now we report between 600 to 700 cases with a variable number of deaths. Now, how does Sri Lanka compare to other countries? Sri Lanka, sorry, this number of cases is wrong. This was actually a old slide. I don't know if this is the right presentation, never mind. So, as of now, we have 29,000 cases with 142 deaths, and the number of deaths per million of population is around 7. So, when we compare to countries like US, UK, Italy, and France, we are doing quite well. But when we compare to countries like Taiwan and Thailand, they have been somehow able to control the epidemic. We were there once where we were one of those countries that had controlled the epidemic, but because of what happened in early October, it had spread to all over Sri Lanka. And as all of you know, now patients are being reported in all over Sri Lanka, and quite of them without any contact with the positive individuals. Okay, so just give me some time because I think there are some technical issues happening. The centers may be sorry for that introduction. There was a technical difficulty, but anyway, just to control it here, then what control කරන්න බෑ. So, as you know, this SARS-CoV-2 virus belongs to the family of these coronaviruses, and if you're familiar with what happened in 2008, 2003, the first SARS-CoV virus was identified from Hong Kong, again from Chinese origin, and we believe that the intermediate host is this cat, a bat virus which was recombinated in a cat and then infected humans. So the MERS virus is another SARS-CoV virus belonging to the same family, and again it is originated from the bat and recombined in a camel and then infected humans. So MERS is still around. So the mortality rate of SARS-CoV-1 was around 10%, but in MERS it is like 33%, and possibly because of this high mortality and less incident of asymptomatic infection, these viruses didn't spread. Now the current SARS-CoV-2 virus, also we know that definitely it did originate in a bat, but we are not exactly sure about the intermediate host, which we think is a pangolin. The important thing about SARS-CoV-2 spreading compared to the other beta coronaviruses is because of the proportion of asymptomatic infections. So if you take a disease like Ebola, that has a very high mortality rate, so it kills a lot of people, and then the transmission is less because you don't there are no such individuals called asymptomatic individuals. But when you have a lot of asymptomatic individuals, they happen to spread the infection a lot, mild and asymptomatic individuals. Because if you have a lot of symptoms, if you are ill, then you are unable to go around and spreading it. Now, how does this infection spread? Now, although we don't know much about this virus currently, how it spreads is quite well characterized. So, the main mode of spread is by droplets. When a person speaks, sneezes, or coughs, the droplets are spread to the people nearby, and also there is aerosol spread. So, and the aerosols generated by individuals differ. So when you speak, so certain individuals generate very small aerosols which can go for a long distance. Some individuals produce bigger aerosols. So the aerosol particles depend on how you speak, the speed you speak, the size of your larynx, the opening, closing speed of your larynx, and depending on that, some people might spread to a longer distance and generate more aerosols than certain other individuals. So aerosol spread is there, and this has been thought to be one of the main causes of spread in concerts, in where there is singing choir practices, weddings and funerals by so-called super spreaders. So super spreaders are responsible for the majority of spread, unlike individuals who just generate droplets. And of course, we know that this virus is present in feces. So you do have infective virus in individual's fecal matter. So it is recommended that if you have a COVID patient at home, so in a lot of other countries, if you have COVID, but if you don't have symptoms, in other words, if you are not ill, or if you have mild symptoms, which is if you don't have symptoms that warrants hospital stay, so those individuals actually stay at home. So, but if you are COVID positive and you are at home, you would want to protect the other members in your family from getting the infection. So, and if you only have one toilet in that house, what is recommended is after you pass feces, to close the toilet lid when you flush and keep it closed for 5 minutes. This is because, again, in fecal matter, when you flush a toilet, you can generate aerosols which become airborne inside the toilet. So when somebody else uses the toilet, they can inhale the virus, which can cause infection. So the main mode of transmission from fecal matter is because of aerosol generation and not because of fecal transmission. So even during this where sewage is treated, there are treatment facilities. There is sewage treatment in those sewage treatment plants. Also, there is a lot of aerosol generation. So in such instances, also asked to, so they can generate high load of aerosols from fecal matter. So you have to take care from those. And of course, so depending on the size of these aerosols, they can infect the individuals. So the next question is, after you get exposed to an individual with COVID, how long does it take for you to get infected? Now let's say I have COVID right now and I speak to somebody, and tomorrow only that person gets to know that I have COVID. So when does that person get infected? So the incubation period, in other words, the time taken for an individual to be infected and also put out the virus varies between 5 to 7 days. It can be as early as 3 days, but generally speaking, people don't think that they are infected or infect other people within the period of 3 days of exposure. So that is important because a lot of people panic after being exposed to a COVID patient that you should have a PCR the following day. That is absolutely useless because it takes time for you to actually, if you are going to have COVID, it takes time for you to develop COVID. So doing a PCR the following day is useless. So this is why it is advised to wait 5 to 7 days before you get a PCR done if you had an exposure. So that is the basis behind that. And after you, so when you get infective, so if you develop symptoms on a particular day, you start being infectious 48 hours before you develop symptoms. So 40% of the infections are thought to occur during these 48 hours before you develop symptoms. So even people, before they know that they have symptoms, they will be infecting others, and 40% of infections happen like this. And after you actually develop symptoms and you know that you have COVID, you can remain infective for a period of 7 to 8 days. If you have mild or if you are asymptomatic. If you have severe disease, individuals with severe disease tend to shed the infective viruses for longer. And this is why in Sri Lanka, in keeping with what is happening in other countries, we are now discharging individuals who have COVID who are asymptomatic. In other words, asymptomatic people are not patients because they are not ill in the first place. So asymptomatic individuals and in those with mild infection, they are sent home from hospitals at 14 days because they do not shed any infectious virus, but they can be PCR positive. So it is very important to remember that PCR positivity does not equal producing infectious virus particles. So now early in Sri Lanka, people were only sent home from hospitals when 2 PCRs are negative. So most people stay in hospitals for 30 days, 45 days, some people even more than 60 days. But because they were PCR positive and intermittently shedding. So that does not equal infectivity. This has been shown over and over again everywhere in the world. To cause infection, you have to have infective viral particles. In other words, you have to be able to culture the virus. So after 10 days, people with mild or asymptomatic illness do not produce infective virus, although they are PCR positive. Now, what sort of symptoms do you get? So most individuals have don't show any symptoms. So they are COVID positive, but they don't know. So this is true for most of the viral infections. Now, if you take something like dengue, which we are very familiar with, about 90% of individuals don't show symptoms. Okay? So, and if you, so a lot of you could be having dengue right now, you don't know. So, but you are not dengue patients because all of you seem very healthy. Likewise, I don't know if there are any COVID positive people also. We have to assume that there are. This is why everybody is practicing social distancing and wearing masks. Okay? So if any of you have COVID right now, if you have the SARS-CoV-2 virus in your bodies, you are not a patient because all of you look healthy. So most of the infections are asymptomatic, which is around 50 to 80%. Some people develop mild infection, which is in the form of fever, sore throat, loss of smell is quite characteristic, including loss of taste, muscle pain, tiredness, and cough, which are seen in a lot of viral infections. Then some people develop moderate illness because of pneumonia and need oxygen but are not critical. So severe illness occurs in about 5% of patients, but depends on the denominator and develop severe illness in form of pneumonia, multi-organ failure, and need ICU care. So the question is, why do you die? Okay, so people want to know, when you have COVID, why do you die and what are your chances of dying? One thing is the pneumonia, or in this medical term called acute respiratory distress syndrome, which is basically pneumonia causing a lot of problems in your lung. But the important cause of death in most patients is thrombosis or abnormal clotting of your blood. So when you form abnormal clotting of blood clots form in various places. So in autopsy studies, they have shown in about 50 or 60% individuals who died, they had this abnormal blood clot formation and they had blood clots in various places in the body. So if you have blood clots in the heart, you can get heart attacks. Blood clots in the brain, you can get strokes. And if you have blood clots in major arteries and in your important organs, you can get multi-organ failure. Another important cause of death is sepsis. So you get infected with a bacteria on top of being infected with the SARS-CoV-2 virus, and that because of the secondary bacterial infection that worsens what is going on, and then you die. So multi-organ failure is it's because of so many reasons, but one reason is because of this abnormal blood clot formation. So what are your risks of dying? I think everybody wants to know that because one of these days very soon, any one of us can get COVID. Okay, so we have to be prepared, and then the question is, what are your chances of dying? So this is of course in New York. Okay, so this is the demography of the New York population. Most of them are in young adult population. And the cases are, of course, again in the young adult population, reflecting the demography. But the deaths are in individuals who are older. So most of the deaths were in individuals over 80 years of age. So if you put, and of course that is not just New York, let's take Asian country. And in South Korea, where there have been a lot of cases, as you know, nobody under 30 died. Okay? So as people age, the proportion of deaths also increased. So if you're 80 and you got COVID, such patients, 7.2% of such patients died. So age is one of the most important factors of people dying due to COVID. Now this is a risk analysis by the Center for Dengue Disease Control. And so they have taken the reference population as 18 to 29 years, which is the current university population. So if you compare these young adult group from 18 to 29 and the risk of dying. So if you take 5 to 17-year-olds, the risk of death is 16 times lower in children 5 to 17 years old. The children up to 4 years, the risk of death is 9 times lower. But if you go above, like this reference group of 18 to 29, the risk of death is 4 times more in the 30 to 39 group. But if you go to extreme of 75 to 84, the risk is 220 times higher. And if you are more than 85, 630 times higher. So age is one of the most important risk factors of death. Then, if you look at the globe, now we know that so many people died in Italy and the West, but not so in certain other countries. So if you take countries now, India had a lot of cases, but not so many deaths comparatively. So if you take the proportion of individuals over 65 years in Italy versus India, you can see a very big difference. So if age is one of the most important risk factors of death, if you have a younger population, you have less deaths than when you have an older population. So, and this is the median age of the population. As you can see, France, Italy, all those countries have a more older population than most South Asian countries. Now, so the question is, I mean, when you look at India, Bangladesh, the mortality rates seem to be lower. So maybe the mortality rates are low in Sri Lanka. So if we just come to that question, so this is mortality rates in India in comparison to many other countries. Italy is number one. Italy has one of the oldest populations. Now India has a mortality rate of 1.87%. One thing, this statistic is a little bit wrong, the Indian death rate. So we work with a few quite a few Indian scientists, and they just said to multiply it by 5 to get the proper statistics. It's about that much wrong. So one thing is statistics are wrong, but even if you multiply it by 5, I think still India could be having a lower mortality rate. And what does this mean? So, but when you compare India with the country like South Korea, so this is South Korea. As you can see, most of the deaths in South Korea occur in old age groups. But most of the deaths in India are between two, like there's a quite a large proportion in the 40 to 49-year-old age group dying in India when you compare to South Korea. See, almost very few deaths in South Korea in the 40 to 49 age group, but see what is in India. So this is the light pink one is the percentage of individuals in that age group in the country versus deaths. So as you can see, and the proportion, disproportionately high deaths in 50 to 59, whereas when you compare to South Korea, that is not the case. So Indian death rates are lower, yes, but quite a lot of deaths have occurred in the 40 to 49 and 50 to 59 age group, which did not happen in Western countries. Okay, you did get a lot of people dying in those countries, but they were older. But in India, it's a different case. Now, why is that? This is because the risk of death depends on other things as well, like cardiovascular disease, presence of diabetes, respiratory infection, chronic respiratory disease, hypertension, cancer, and smoking. So, risk of death is higher in those with heart disease, diabetes, obesity, chronic lung disease, and cancer. And if you look at diabetes in different countries, So the prevalence of diabetes in India in rural areas is like 3 to 7.8%, and urban areas 10 to 14%. In Sri Lanka, the urban is prevalence of diabetes is 12.8. You know that we have a huge diabetes problem. In Colombo, this is a recent study by Dr. Noel Sundaram and others in 2017. In Colombo, the prevalence was 36.1% in those aged 41 to 60-year-olds. And when you compare to UK and Italy, you can see that we have a huge diabetes problem. So now, will we have a high mortality rate or not? Now, we know that we have 29,000 something cases in Sri Lanka with 142 patients already dead. Now, of those 29,000 something patients in Sri Lanka, quite a large proportion, about 85% of them are asymptomatic individuals. This is because, unlike in Europe, still they only test symptomatic individuals. They do not test asymptomatic individuals. Europe is talking about this now, whether they should be testing asymptomatic individuals. So their case number are symptomatic individuals. Whereas our 29,000 something includes a lot of asymptomatic individuals who are not patients. Okay, they are a patient by definition is somebody who's ill. So these are not. So of these 29,000 something patients, 80% are not ill. So we take them out of the equation. So the actual number of patients, if we talk about symptomatic patients, is like 5,000 or something like that. You can do the maths. So of those 5,000, we have lost 142. And all of you know that the major incident is currently in the certain isolated areas in the CNC. So we know that those are low socio-economic and very highly dense populations. And if you look at the population demography in those areas, you have a lot of migrant people coming in to work in Colombo, to work in various supermarkets, this and that. So in the CNC area, we have a generally younger population than the rest of Sri Lanka. We have to keep that in mind as well. Okay? So the individuals over 65 years in the CNC area, in the isolated areas, is different to the rest of Sri Lanka. The transmission dynamics are also more. So the death rates that are occurring in the CNC might not reflect the death rates that will happen if the disease spreads to the rest of Sri Lanka. Okay? We need to understand that. But at the same time, people have been talking about whether certain infections, prior infections like previous corona infections, the presence of the BCG vaccination, all those, whether those will be protective. We don't know. Okay? And I don't wish to find out also. Okay? But I think we will find out. Okay? So this is not something we want to find out whether corona spreads, what will the mortality rate in Sri Lanka be? I don't know if anybody wants to find out, but maybe we will find out one of these days. But that is just some my opinion. And of course, when do you die? Now, a lot of people, when they get COVID, they are like very scared, especially if they get symptoms. Let's say that you're like 65 years old, you have diabetes and some other problems, and you get COVID. When will you die? Will you die the next day? Okay. So now, based on the data from IDH, which is one of the hospitals which COVID patients are admitted, quite a lot of patients in their 80s and even 90s did not have any problems. They didn't get pneumonia. But if you get pneumonia and problems, you usually start developing severe illness or pneumonia, usually around after day 6 of illness, developing symptoms. So unlike dengue, where you sort of get bad very early, in COVID, the period where you get back, that is the second week of illness. The first week you're okay. And death usually occurs around day 19. This is the average time it takes a person to die without, depending on the type of intervention. Okay, now coming, of course, this is a nightmare, we want to get out of it. So when will we see the end of COVID? Now, of course, for a lot of infectious diseases like smallpox, measles, mumps, rubella, we only saw the end of those infections after vaccination. Okay, so what is the state with the current COVID-19 vaccines? So there are several questions. So how will we use a COVID-19 vaccine? Will we be inducing herd immunity, which I'll tell you what that is, versus immunizing only the vulnerable population. Now, if you take something like influenza, I'm sure a lot of people sitting here would not have the influenza vaccine because most people look very young. Okay? So the influenza vaccine is only given to people at high risk of dying or developing complications. Influenza vaccine is not given to young adults. So will this COVID vaccine be the same, or will it be given to everybody to induce herd immunity? Can we wipe out COVID-19? Now, I don't know if you know that there is this mink strain. So there are mink farms in Europe because they make meat reports with minks, and the minks got infection in those working in those farms. So humans can, like we were infected with some this intermediate host, we can infect mammals. So if it goes to a mammal, if it gets recombined, will we get an infection again? So can we actually wipe it out? There have been enough instances where cats and dogs have also got infected. Okay, so if you have another host, can you eradicate it? And how long will immunity last? Will we have to have yearly immunizations? Like like for influenza, if you get an influenza shot, it only lasts for a year. You have to get an influenza vaccine every year. Okay, so will we have to have a COVID vaccine? Will we have to have the COVID vaccine every year? So now to explain about herd immunity. So if you have a population and nobody is immune to a particular infection, and you have a few individuals with infection introduced into that community, it spreads and causes infection like that. But if you have a few people who are immune, so the transmission is less because you can't infect individuals who are immune. So then less people get infection. But if you have a lot of people who are immune, then you can't spread the infection. So there's a thing called herd immunity. Now this depends on a thing called the epidemiological value called R0. So the R0 value is the number of people infected person infects. So if you take something like the infection like measles, measles is very infectious. So a measles patient infects 12 to 18% of others, a single measles patient. So if you want to stop measles transmission, about 92 to 94% of individuals in a community should be immune to measles. Now, if you take something like H1N1, which all of you have heard, H1N1 doesn't transmit that fast, and the R0 value is 1.6, which is one individual only infects 1.6 other individuals. So if you have a herd immunity of 40%, you block the transmission. But for SARS-CoV-2, the R0 value is put at 5.7, it changes. And so you need a herd immunity of 82.5%, which means if you are going to use a vaccine to stop COVID transmission, we have to induce immunity in 82.5% of our population to stop transmission. So can you do that by vaccine? So now there's a lot of interest about vaccines and a lot of questions whether we took shortcuts in developing these vaccines. Because as you know, there's this vaccine design and development, the clinical studies, then animal studies, then you have a phase 1 which is given to healthy volunteers who are not infected, phase 2 to actual patients in small numbers, phase 2 multi-center in different centers, and then only you get the regulatory approval and then go into production. But in this instance, everything has happened in like 10 months. So how was this? So this preclinical design and experimental stage was already done. So for instance, if you take the Oxford vaccine, they had already done this part and animal studies for the SARS-CoV-1 virus. Okay? So in this instance, what they did was they substituted a protein, the spike protein of the SARS-CoV-1 virus with the SARS-CoV-2 virus. So the vaccine platform was already there. And then what happened here was rather than finishing one phase and going on to the other phase, when one phase was going on, the other phase started in the middle. So that one phase overlapped with the other phase, and in the phase 3, when the phase 3 study started, the production also started. So by the end of, when the phase 3 ends, the vaccine is ready to be given. So now you know that the Pfizer vaccine was given to UK patients yesterday, the first lot, and so the phase 3 trial is sort of not yet finished, but then the vaccine was given. We'll come to that. So now there are 10 vaccines currently undergoing phase 3 clinical trials. Some are from China, there's Oxford vaccine. two companies, and then the Russian vaccine and the Pfizer and the Moderna vaccine. So I'll just explain briefly about some of the platforms because some of them are new platforms. Now all of you are familiar with these inactivated vaccines, which most of us have got, like the triple vaccine and so on, are mostly inactivated vaccines. So in those you inactivate the virus using formalin or something like that. But here we have two virus vaccines. One is the Oxford vaccine and the Russian vaccine and several others are using this adenovirus vector, which is a replication incompetent virus. I'll talk about that with the spike protein inserted. And then you have these RNA vaccines or mRNA vaccines. So how do those work? So these are just and the mRNA vaccines, because it is unstable. mRNA is unstable. You have to store them at very low temperatures. So the Pfizer vaccine should be stored at -70, the Moderna at -20. The Oxford vaccine, AstraZeneca vaccine, that is at normal fridge temperature, and so is this Russian vaccine. So now, what is a adenovirus vector vaccine? So if you talk about the Oxford vaccine, what they have done is they have taken a chimpanzee adenovirus, which also infects humans. You can make it infect humans. Then inserted the SARS-CoV-2 spike protein. So now when the virus infects somebody, the virus proteins are transcribed by the cell host, and the host develops virus spike proteins. But here, this virus is non-replicating virus. So after it infects, it does not replicate within cells. And in the Oxford, they have used a chimpanzee adenovirus because if you use a human adenovirus, all of us have been infected with human adenoviruses before. So we have antibodies to human adenoviruses. So if you give a human adenovirus, you might be our immune response might reject the vaccine. It might neutralize the vaccine before the vaccine can actually do anything. So this is why Oxford University has used the chimpanzee adenovirus. However, the Russian vaccine, they have a human adenovirus, so we don't know how that will, the efficacy of that will be when we actually find the trial data. So that is about adenoviral vaccines. And so far, these type of vaccines have not been given before to humans. And then you have these mRNA vaccines. So this is the Moderna and the Pfizer vaccine. So mRNA is put into this ribosome, and then you inject it. It goes into the muscle, and the mRNA is released. So the mRNA is translated by ribosome. So this is the spike protein that is translated and expressed on the cell surface. So you get antibodies to that. It also is processed inside the cell in the T and expressed in certain molecules, so that you get a T cell response as well. Now, when we talk about vaccines, we have several questions to answer. First of all, the seroconversion or the presence of neutralizing antibodies associated with protection. How long do antibodies last? Because we know that antibodies protection is not lasting forever. Is it important that you have a T cell response also? Because for some vaccines like chickenpox, it is mainly the T cells that are working and not the antibodies, whereas for some vaccines like hepatitis B, it induces a strong antibody response but not a T cell response. Does the vaccine prevent both mild and severe illness or just severe illness? Do we need yearly boosters? And what are the long-term implications like vaccine-induced disease enhancement which was seen with dengue? So now just about the antibody responses, I'm just showing two slides of Sri Lankan data to show how long do they last. So these are our data on our patients. So unlike other illnesses where you develop antibodies at the end of, definitely at the second week, there is a delayed in antibody response for SARS-CoV-2, which is also seen for SARS-CoV-1 and SARS and the MERS virus, which are in the same group of viruses. Okay, so you get a delayed immune response, and some individuals. So these green dots are individuals with mild infection. So individuals with mild infection, some of those then have a very delayed immune response, and some people don't develop it. So irrespective of the disease severity, if you look at the antibody response, the antibodies do form in the majority of individuals, but after 90 days, 48.5% of individuals lose antibodies. And you can see the time point A, which is 3 to 4 weeks, and time point B, which is after 3 months, how the antibody responses decline in most individuals, but not all. So this is available as a preprint if you want to look at it. So what are the implications of the vaccines is a good thing we need to answer. So now the Pfizer vaccine. So now this is yesterday given to patients in the UK, and so we don't know how long the immunity lasts. So in the patients who received the vaccine, the immune responses were good and were protected, but again the follow-up period is very short because the vaccines were initially given in July and it's still end of this is data by end of November. Then you have the Russia vaccine. But if you look at the Pfizer vaccine, they have actually analyzed the cases in 164 individuals. Again, not a big sample size. Now, the Russian vaccine say that it has a 90% efficacy, but this is analyzing 20 patients, which is an even smaller sample size. And this is after 3 weeks after vaccination. More data currently is not available. We have the Moderna vaccine. Again, no data available, but they say that there's a 94% efficacy. They don't say how many patients are analyzed to come to this data. We have the Oxford vaccine, which has two dosing regimes. The two dosing regimes gave two different results. A low dose and followed by a high dose one gave a 90% efficacy versus two high dose vaccines had a lower efficacy. So they have tested in 24,000 volunteers and have analyzed the vaccine responses in again a smaller sample of 134 individuals who got infection. But the Oxford vaccine is the only vaccine which evaluated the responses in individuals over 70 years, and irrespective of the vaccine dose, they induce the same response as younger individuals. So then this is one of the Chinese vaccines, and they have said that their vaccine induces quick immune responses, in other words, antibody responses in 14 days, and because of that, they believe that the vaccine is suitable for emergency use. So they have not analyzed any cases of how many people got it or not. It's just that because it induces immune response, it's suitable for emergency use, but the antibody responses seen in this vaccine was less than the other vaccines. And so this vaccine has been given to over 1 million people in China now because they believe it's good for emergency use. And so the people who have received the vaccine have already had some mild symptoms but not actually assessed properly. And this is a comparison of the antibody responses for different vaccines. So most vaccines had a T around 300, whereas this particular Chinese vaccine actually had less antibody responses. What that means, I don't know. So just to summarize, many vaccines undergoing phase 3 trials, and the interim analysis looks promising. The Pfizer released its data this morning, which I just saw. So they have followed up patients for up to 90 days, and there is a big difference in those who got the vaccine and those who got the placebo, the disease incident. But some of the patients who did get the vaccine also developed severe disease. So which means that it's not 100% protective, and how long it lasts again we don't know. So now we are doing several studies. So these funding of our antibody studies and all other studies are done by several granting agencies, and these are our Sri Lankan collaborators from IDH, from Surang, who was at Tanzania, and we work very closely with the Colombo Municipality Council, and this is the regional epidemiologist and CM Chief Medical Officer, and our foreign collaborators, Professor Hammo, then Tushan from University of Sheffield, other people from Oxford for T-cell studies, and we are also doing the neutralizing assays with in Singapore, and this is the whole team. So we are doing a lot of PCR, and it's Dr. Shandila Jayewardenepura who is actually running the show, and actually because doing most of the work and not me. I would like to say that, and really thank him for all the hard work he's doing. And this is all our team members who are involved in the research and also PCR. Thank you.
Thank you very much.
You take questions, yes.
Thank you very much, ma'am. We have actually a lot of questions from Q&A session. Dr. Udaya Ratnayak is asking, what is your opinion about recently identified indigenous treatment by Mr. Dhammika Bandara?
Okay. So I think okay, that's a good question. People are interested in it.
Yeah.
So I think not just Mr. Dhammika Bandara. I mean, so many other Ayurvedic physicians have come up with treatment for COVID, and also Paramparika treatment methods and Helavedakava, so those are three different things. So currently we are investigating a medicine with the Navin Ayurveda, doing a phase two open label clinical trial. We are trying to do it. We have applied for ethics. We are in the process of also applying for ethics for a Paramparika one. Because they actually, those who institutes and the Dhamaka didn't claim that it actually cures corona, they just want to see whether it works. How about the Dhammika Bandara Kenya? I think the committee is appointed to do a clinical trial. So according to my knowledge, this committee comprises of both Western and Ayurvedic doctors who have experience in this, and so they will be doing a double-blinded, randomized control trial to see if the Dhammika Bandara Kenya will work.
Thank you very much, ma'am. And there's another question again from Dr. Udaya Ratnayaka. Currently, introducing vaccine success ratio is 90 to 95%, according to the inventors. Other 5% means what? Is this that there is a risk of 5% to spread the virus?
Is that we have 7.6 billion individuals in the world, and although the vaccines will be registered, and even if we find it is effective, how soon we will get the vaccine? Now, under the COVAX agreement, the WHO is going to provide vaccines for 20% of the Sri Lankan population, which is like 4.2 million. I am not sure if we get. We will get opportunity to get more vaccines. So vaccinating 20% of Sri Lankans is not going to stop the transmission. So if by any chance these vaccine manufacturers are able to produce more vaccines, then I think there will be opportunity for more Sri Lankans to receive the vaccine. But according to my understanding in the vaccine committees I am in, probably around next September or so, we will get, I'm not sure again whether we get 20% or 10%. So something like, we will get something like that, which is not going to stop transmission. So it will be given to those who are most vulnerable and high-risk populations. So until there is enough vaccine available to immunize everybody. Again, if you need this vaccine is not going to provide long-lasting immunity, it also means that we will have to revaccinate these vulnerable and high-risk populations every year. So these are some of the questions that we need to think about.
Thank you very much, ma'am. There's another question. Amalka Chandraratne is asking, ma'am, would the immunity develop through the vaccines created in foreign countries, which has a significantly different strain of virus than our country? As an example, USA, Russia, China, so work effectively against the strain of virus infecting us?
I would like to very categorically say there is one SARS-CoV-2 virus. Unlike if you take dengue, there are four dengue viruses. So something that is effective for dengue 1 is not going to work for dengue 2 because there's a 75% difference between the different viruses. But if we take the SARS-CoV-2 virus strains, they only differ by about 1 to 1.5%. So that is a very small change. So something, and our strains are quite similar to the European and actually US strains. So, the vaccines developed in those countries will, of course, be effective for us because our strains are very similar to the US and the European strains. But then the other question is, will the strains remain the same? It's a different issue because these are RNA viruses. So by the end of next year, whether they have significantly evolved, we don't know. So whether we will have to have a slightly different vaccine by the end of next year, is again something we need only time will tell.
Thank you, ma'am. And there's another question from Lihini Vanyarachi asking, is it possible for us to access this presentation? Please run this webinar concludes for future reading. Okay. We'll make sure you will get the presentation. And I think our panelists also will have some questions to ask from them.
Of symptoms. So our quarantine period still is 14 days in the institution and another 14 days at home. What are your comments about this reducing the quarantine period?
About now our 14-day period in hospital, that is just to make sure, because by day 7 most people are not infective, and after day 10 actually nobody is infective. So it's just to be more sure that people are kept an additional 4 days in hospital for day 14. My health ministry recently released a circular 2 or 3 days back saying after these patients go home, another 14 days of quarantine at home is not necessary. So the Ministry of Health, the circular is out I think 2 days or 3 days before. So after you go home, a further 14-day quarantine is not necessary, because this is all based on scientific data that PCR positivity does not equal infectivity. You can be PCR positive for a long time, even after 3 months. And if somebody becomes positive, if you do a PCR on somebody, let's say 2 months later, and if the person is positive, that doesn't mean it's a reinfection, it is ongoing oral infection of intermittent shedding. So this is why, based on the evidence from all the scientific evidence, that the Ministry of Health, I believe, has taken the decision that another 14 days of home quarantine is not necessary.
Professor Neelika, thank you very much for your very valuable, timely, important presentation. So, as an environmentalist, so then just I want to know, so then you mentioned about the aerosol, and so then usually this virus get infect to another person by aerosol. So then is it possible to get this infection by environment? I mean the water or some other thing. So then can we get this virus through water?
Yes. So I thought this question will be asked because a lot of people have asked me these questions in different forums. And just to make sure about my answer, I also consulted Professor Malik Peace. I don't know if you know Professor Malik Peace. He is one of the World Authority on SARS-CoV-2. So I will actually give his answer rather than mine. And my opinion, of course, I thought it's best that I give his opinion. I can show his email as proof if people want to. So his opinion is the risk of transmission from water is very, very minimal, if not, it's not possible. So, for instance, we know that a lot of fecal matter is actually in Sri Lanka and I don't know other countries also is in the waterways, and the fecal matter is infected. So up to this day, I mean, you do get infected viral particles in fecal matter, but when you put it in water, it's very much diluted. There's a thing called infective dose. So just because you happen to have inhale one virus or 2 viruses, you're not going to get infected. And so the water contaminating and causing infection is through the fecal oral route is very minimal. And again, if it is in a sewage pit or something like that at home, the soil filters a lot of things and inactivates these viruses. So his opinion, not only his opinion, when you look at all the scientific data out there, transmission from water and water inside, I don't know, contaminated water sources, transmitting infection to human is almost impossible. That was his answer.
While thanking Professor for the informative explanation on the situation and the impact and the response of the development of vaccine, so when you consider the issues of this scientific response, the problem of developing a good vaccine and the limited impact of it and the reproduction of it. So we Sri Lankans are not capable of getting it as we all in a limited period of time. We have to wait for months and months. If it is to be given again and again, then the Sri Lanka, they find it very difficult to afford it as a poor country, the financial aspect, economic, at the same time, the effective of that. So then, considering all these limitations, then what should be the response of the society and the leaders of the country? Yeah, vaccine may come, but it is having so many limitations, effectiveness, and the problem of making it available for all and buying it again and again. It should be something preventive from the society. Then better if it comes from you until we will be able to have it.
Okay. So that is a very important question because that is the reality. We are not going to get a vaccine. It's true that the UK first person went on yesterday, but as Sri Lankans, we are a poor country and we are not going to get a vaccine to immunize everybody next year. We will get the vaccine to immunize some people next year, but definitely not all. We will not get a vaccine to immunize everybody the following year also. So basically, we cannot break the transmission by vaccinating people. But as I just showed, most of the individuals who actually die or develop severe disease are individuals who are older or who have complications like diabetic, cardiovascular disease, cancers, so-called complications. So if we have a vaccine, like for influenza, you get yearly vaccines for all these individuals to prevent them dying or getting severe. So I believe if we get the vaccine, which we can give to those individuals who are at risk of death. Now, we had an AD cluster. Nobody actually showed much symptoms. So, and when you say that you are curing people, and I know in the news every day, you say that so many people were cured, but so many people didn't have symptoms to get cured. I mean, you have to be ill to be cured of something. So, all these Navy people, the people in the garment factories, we had so many cases, but most of them did not have symptoms. So, in that case, all of us are being careful to protect the vulnerable population. Because when if the vulnerable population is infected, then we have a very high mortality like we see in Italy and all these other countries. So we are actually taking all these precautions of social distancing, proper hand hygiene and all these measures to protect our parents, our grandparents and those who are vulnerable because we do not want them, we would want them to be here for a while. And not have a situation where you see what is going on in Europe. So I think until they receive the vaccine and they are protected, we have a responsibility towards the vulnerable individuals for us to be careful to protect them.
Very good answer. Your Indian example is very good for identify the vulnerable people in our region, as the young Indians say, those who are in 40s and 60s are getting it and dying at a higher rate. So Sri Lanka must also consider that particular example compared to the European example.
The virus needs living cells to survive. So
my point is also.
Yeah. So how long is there any evidence how long does the virus last in the dead body?
Dead body. Yes. My also question also the same.
Yeah. So actually, on a dead body, I think there is not much interest about dead bodies outside Sri Lanka. Okay. So these studies have not been done well, but virus has been isolated in dead bodies, not virus, RNA. So there have been PCR positivity in dead bodies because people don't take dead bodies that have been buried to see if they're still PCR positive. But I'm talking of bodies kept in freezers. So we know that bodies are kept in freezers for different reasons for some time, and the freezer temperature is a temperature to make sure that the body does not undergo crisis and putrefaction and all these things. So in the freezer conditions, the RNA positivity has been there for even 72 hours, but not infective viral particles. So now we get a lot of postmortem samples, and it is difficult, and the advice is after basically 36, within after 18 hours, the PCR positivity is very less in the body. So even if you get negative PCR, you can't exactly exclude COVID because the virus disintegrates. I mean, true that the body is in a freezer, but still it is not. There is even if you keep a body in a freezer, there is autolysis of cells. The cells destroys the cell wall, and so a virus needs a living cell. So the virus can't replicate after death. So now if he has COVID, I will maintain my social distance from Professor Patnala. But if I have a dead body here, there is no need to maintain social distance. The dead body doesn't breathe. So as long as a person doesn't breathe, the person cannot generate aerosols. A dead person can't cough, doesn't breathe, so doesn't disseminate virus into the air. So a dead person is far safer than a living person with COVID.
Now you have done this virus sequencing, and we heard it is similar to this time. The virus is similar to the new type that is there in Europe, even though you said it's the same virus, probably with the mutations and the changes. So does it mean that it is a strain that we already had with the mutation, or is it had come from Europe? Because it is again a topic that's being debated.
So that's a good question. So when we analyze the sequencing data, the current viral strain is very different from the viral strains that circulated in the Kandahar outbreak in the before that. So the current viral strain was not seen previously in Sri Lanka. So it means that it was introduced in Sri Lanka, and when you look at the phylogenetic analysis, somewhere early September. So it came somewhere early September from somewhere. Now the issue is where it came from. So now let's imagine this scenario. Let's say somebody from Australia comes to Sri Lanka today and gets COVID from Sri Lanka and goes to US. Okay, so the virus, our virus strain is similar to the European virus strain, but the person who came from Australia to Sri Lanka and went to US actually got it from Sri Lanka and not Europe. So if they do a study, they can't, although it's European strain, they got it in Sri Lanka. So now we have a European strain in Sri Lanka. So if a Maldivian person comes here and goes back to Maldives, that person didn't get it from Europe but Sri Lanka. So you can sort of say that the strain originated in Europe, but you don't know exactly where it came from Europe because we don't know how the source of infection.
Thank you very much, madam, on your very valuable.
Now, considering this passive aspect of the people who work it, there's a higher percentage of passive, limited number of active and asymptomatic and asymptomatic. So some people take it for granted, even thinking the situation in America is paying high cost for that. So the people who take it granted should be educated regarding the vulnerability of their own people and people at home. So that point must be highlighted as one big education, I think, after summarizing this.
Yes, that's a very valid point because young people, I think by now so many people would have got COVID. So they tell their friends, yes, I was positive, but I know some people say I was positive, but I didn't have a headache even. So if you don't even have a headache, so that is no illness at all. So this word spreads that, okay, you have COVID and you don't have any issues. So yes, young people, as I just showed, in Korea, South Korea, nobody under 30 died. So young people are okay, but it's your social responsibility. If your parents get it might not be okay. If your grandparents get it might not be okay. So you have to. So you might, as university students, might be okay. They are in the preference group of 18 to 29. Okay. So it's unless they have some underlying illness, it is very very rare for anything to happen to them. But that doesn't mean, but they will be transmitting infection to vulnerable people and they will die. So this is the social responsibility that we need to think of.
Thank you very much, ma'am, on your very valuable insights shared on this pandemic. And of course, as you said, we all have a social responsibility on this matter. Your speech is very interesting and clear. We learned a lot about COVID-19 and SARS-CoV-2 virus from you. I would like to take this opportunity to sincerely thank you and your team on behalf of our whole country, Sri Lanka. We are in debt to you for all your hard work and effort you put to save all of us. We are very proud of you, Professor Neelika Malavige. Thank you very much, ma'am. Now it's the time to hand over the tokens of appreciation. We would like to mark our gratitude. May I now invite Senior Professor Padmalal Manage, the Dean, Faculty of Graduate Studies, to hand over the token of appreciation to Professor Neelika Malavige. Professor Malavige, ma'am, as a token of our sincere thanks, please accept our modest gift. Thank you very much, sir, ma'am. This concludes the second theme talk of the 7th International Conference, iCMA 2020. Thank you very much.